I call upon Dr. Sudhir Kadam to give his overview onto neonatal hearing screening. Dr. Sudhir Kadam is from Miraj. He has his own hospital. From a small town, he has done a large number of series. Over to Dr. Sudhir Kadam.
Thank you, ma'am. Good evening, all. With inspiring talk from Uppal sir and explaining details regarding adult CI scenario by Minesh sir. Now I will say something very, in a very brief way. I will explain how this newborn hearing screening can be done. So roughly, there are 4 lakh children today under age of 4 with severe to profound hearing loss, and approximately 1 lakh additional children born each year with severe to profound loss in our country. So why to go for neonatal hearing screening? So almost 3 to 4 children in 1,000 live births are in need of hearing intervention. If not addressed in critical time, will definitely end with impaired speech. So identification or screening of hearing loss can be done with otoacoustic emission and automated ABR. Grading of hearing loss can be done and a firm diagnosis will be done with BERA. Patient will be kept under periodic follow-up, and to plan intervention strategy, we have to go for neonatal hearing screening. This is done by 2 ways. Either it is universal, that is 100%, so to screen all babies live birth, and high-risk neonatal hearing screening program, that is babies born out of high-risk pregnancies are only screened. So there are a lot of dilemmas actually. Many times patient comes to me, pediatrician will refer patient at age of 1 month for BERA. So lot of dilemmas regarding when to go for this OE, BERA, and what is early hearing diagnosis and intervention. So first of all, we should know whom to screen. Why we want to screen them so early, when to screen them, and who is going to screen, whether ENT surgeon, audiologist, or pediatrician, who is going to screen them. Is there any protocol, and what are tools to screen these children? What intervention modalities are there for these children once we have screened them and diagnosed with hearing loss? Whom these children should be referred, and what happens after referral? So Western and many developed countries have UNHS compulsory. We have our protocol with launch of National Program for Prevention of Deafness in various state programs with lot of positive steps from government in form of establishment of DICs at district levels, financial assistance for hearing aid, CI surgery, rehabilitation of Divyangjans. But still, we are lagging very much behind as far as almost we are in a start of less than 1% hearing screening in our country at present. Regarding high-risk neonatal screening program, up to 4 weeks, this is a fixed list given by JCIH, like prenatal infections, then prolonged labor, ototoxic drug, NICU admission, then low birth weight. These are some of list given. It's a standard list given. Whenever child presents with such a history, it's our duty that we should screen those kids. Also, from 4 weeks to 2 years, particularly parents concerning hearing delay, then delayed development milestones, syndromes, bacterial meningitis, neurodegenerative disorders, head injury, mid-layer infection. These are the children whom we should screen because they are at risk of hearing loss. Apart from this list, there are some congenital infections including meningitis, cytomegalovirus, toxoplasma, rubella, herpes simplex, then syphilis. Also, NICU admission for more than 2 days, regardless of duration of therapy, with this ECMO, then assisted ventilation, ototoxic drug, and hyperbilirubinemia, which requires exchange transfusion. These children are at risk of development of sensory hearing loss. Now, why to screen them early? Because there is a concept of neuroplasticity. What happens that auditory system does not mature without stimulation. So brain needs some sound stimulation so that auditory system will mature. So deafness significantly impairs development of auditory system, whereas early auditory stimulation allows maturation of the system. So most important period of language and speech development is in first 2 to 3 years of life. So most hearing impaired children in India miss out on this critical age of language learning. Untreated hearing loss can mean that some children never learn to speak. So at birth, there are some auditory cells. Then once this auditory cortex is stimulated with sound or hearing, there is a development of this auditory memory which generally declines after 5 years of age. So whatever intervention we are planning after 5 to 6 years of age is not going to have much benefits as far as development of communication are concerned. So ultimately what happens, this visual brain takes over to auditory brain and child will start developing this non-verbal modes of communication. So auditory stimuli during first 6 months of life are very critical for development of speech and language. There are a lot of studies, they have shown that infants who receive intervention before age of 6 months have better school outcomes, improved language communication skills by age of 2 to 5 years. So without early intervention, children with hearing loss will show irreversible deficit in communication, psychological skills and literacy. They are more likely to have academic underachievement, problems with employment and psychological distress. So unaddressed hearing loss will end with listening and communication skills, then language and speech development, cognitive issues, education, employment, social isolation, loneliness, mental health and identity, and again a social stigma. So these are very popular studies, Swish and Loki study. What they have concluded is that early fitting of hearing devices with evidence-based candidacy criteria results in better language. Early fitting of hearing devices also more beneficial in presence of additional disabilities and auditory neuropathy spectrum disorder. And parents' report is a very significant predictor of language and psychological development of child. This is one study by Canadian Pediatric Society where they also say that early intervention translates into improved language outcomes, and in well-run program there is negligible harm from screening. So there was a statement by this JCIH where they say in 2019 they address issue with giving importance to early identification, early intervention, follow-up and follow-up of these kids. So what they recommended is that child should be screened below 1 month of age with either OE or automated ABR. Then they should be diagnosed with hearing loss, that's BERA, to confirm the hearing loss by 3 months age, and the child should be taken into intervention by 6 months age. So this is nothing but called as 136 formula. Later on, WHO also recommended on similar way, that's the 136 principle, that is screening by 1 month, then diagnosis by 3 months and intervention by 6 months. Also, after that, Indian Academy of Pediatrics also came up with some consensus statement in which they said, again they suggested same, that is 136 formula. So, OE, ABR and BERA, these are basically objective tests of hearing function. They are useful in neural hearing screening as a part of early hearing detection and intervention program. They do not require any response from subject, and these tests are generally, preferably should be done by audiologists, speech language pathologists, pediatricians, ENT, so at least screening can be done by ENT surgeon, then PG residents, then teacher for deaf, nurses posted in labor room and NICUs also. Can be, this OE and ABR can be done as being an automated test. OE is a function of, that's a cochlear function, test of cochlear function. ABR, it gives information regarding functioning of retrocochlear auditory pathway. Okay, I'll end immediately. Okay. And BERA, this is the most effective method of estimating hearing threshold and assessing retrocochlear auditory pathway. This is a two-stage protocol. Once OE is refer at first attempt, we have to again retest, and that child has to be monitored properly whether this test turns into pass or refer, and then child should be submitted for BERA for confirmation of hearing. I'll just skip this slide. So there are some limitations with hearing screening. UNHS will not identify progressive and late onset hearing loss. False positive rate is around 2%. Effective program needs a large amount of organization, should have integrated diagnosis, intervention and follow-up. In developed world where the state pays for healthcare, benefits of NHS outweigh the costs. However, the cost effectiveness has not been established in developing countries. To be really effective, screening needs to be coupled with an early intervention program, without which there would not be benefit in early diagnosis. So in our country, with high attrition rate in follow-up and cost effectiveness of UNHS, as well as its comparison with targeted screening, needs to be evaluated. And it's an urgent need to start national or Maharashtra state level newborn screening program. Thank you so much.